I will be speaking about the optimum blood pressure for dialysis patients. At the end of the talk, you will definitely learn that we have yet to learn what the optimum blood pressure is after, 60 years after dialysis became available. So I'll be speaking briefly about the epidemiology, then define hypertension in dialysis patients, and then pathogenesis and treatment. My emphasis would be on hemodialysis patients, as this is the dialysis modality on which most of the literature is available. As was presented by the earlier speakers, hypertension is quite common among patients with advanced CKD, but because of the differences in definition, the prevalence rates reported in the literature are quite variable. Like 50 to 60% of patients on maintenance hemodialysis, and about a third of patients on PD are reported to have hypertension. Hypertension is generally more common among patients that are just starting dialysis, over 80% compared to those who've been on dialysis for some time. And this, as I will discuss later, is related to volume issues. And hypertension is generally poorly controlled among dialysis patients. So the first question is, how do we define hypertension among dialysis patients? In the past and amongst us, we still use pre-dialysis and post-dialysis measurements to define hypertension, but as I will show in a little while, this is not appropriate. On the basis, if you define hypertension on the basis of the pre-dialysis blood pressure, you all know about the J-shaped curve, the U-shaped curve that relates overall and cardiovascular mortality among patients on dialysis, in which patients with lower blood pressure levels have been shown to have higher cardiovascular mortality. This is I'm sorry, the slide does not show very well. Part of it has been cut when I tried to copy and paste. This is a study that was published in 2005 from the Davita group in the US, involving about 40,000 patients, in which patients with lower blood pressure levels, systolic blood pressure levels, and normal blood pressure levels had higher mortality than patients with higher blood pressure levels. The death rate was lower in blood pressure between 160 to 169 systolic. And the same thing was true regarding diastolic blood pressure. Patients with a lower and normal blood pressure had higher mortality. But pre-dialysis and post-dialysis blood pressure, we must realize, are unreliable, because we do not measure the blood pressure in our dialysis units using standard blood pressure measurement techniques, including rest and so on and so forth. Patients' blood pressure are measured in a very hectic situation when patients are scared of being needled and so on. So these blood pressures do not represent the true blood pressures. And studies have come to show that pre-dialysis and post-dialysis blood pressure do not correlate with end organ damage and outcome. So the current consensus is that hypertension is better defined on the basis of ambulatory blood pressure measurements, if available, and when that is not possible, on the basis of home blood pressure measurements. So ambulatory blood pressure greater than 130/80 over 24-hour monitoring during a midweek day free of dialysis is what defines hypertension if you use ambulatory blood pressure measurement. When feasible, actually, doing ambulatory blood pressure measurement for the whole period, the patient is off dialysis for 48 hours, gives you a better representation of the changes that occur in the interdialysis period. When ambulatory blood pressure monitoring is impracticable, as would be true for most of us in sub-Saharan Africa, one can use self-home blood pressure measurements to define hypertension, as well as to follow the response of therapy in hypertension. And blood pressure, according to as measured at home, greater than 135/85, collected in the morning and in the evening over 6 non-dialysis days, which would cover a period of 2 weeks, would define hypertension. And ideally, home blood pressure should be monitored every month. But there would still be patients who would have difficulties doing home blood pressure measurement, in which case one may use office blood pressure on a midweek day free of dialysis, greater than 140/90 to define hypertension. When all this is not possible, one can still use blood pressure measured during dialysis, which generally reflects hemodynamic changes during dialysis rather than the true blood pressure over the days and nights. But one can use peridialytic BP as an alternative. One would use, our patients have their blood pressure measured several times during the 4-hour dialysis that they stay with us. And if we can use the median intradialytic BP, it correlates better with ambulatory blood pressure measurement than either pre or post dialysis. So this is how experts would like hypertension to be defined in our patients on maintenance hemodialysis. And this is just to show that both home and ambulatory blood pressure are better correlated with cardiovascular outcome than pre and post dialysis blood pressure measurements. So these are blood pressure quartiles. So if one uses ambulatory blood pressure measurement, you can clearly see that patients with in the higher quartiles have higher cardiovascular mortality than patients in the lower quartile. And this is also true when one uses home blood pressure. So we should move towards using home blood pressure and ambulatory blood pressure in the definition and follow-up of our patients on dialysis. So if one goes about the pathogenesis of hypertension, as was discussed by the previous speaker, as CKD advances, volume becomes a major factor in the pathogenesis of hypertension. Patients become more salt sensitive, and volume is what actually drives high blood pressure among patients on dialysis. In addition to volume overload, our patients on dialysis have increased sympathetic activity. There is activation of the renin-angiotensin-aldosterone system, arteriosclerosis, changes in endothelium-related vasoactive factors, and treatment with erythropoiesis-stimulating agents all contribute to the pathogenesis of hypertension. This is a repetition of what I just said, but I would like to emphasize that sodium and volume overload are the most important contributors to the development of hypertension in patients on dialysis. We should not forget issues like sleep apnea and the contribution of erythropoiesis-stimulating agents. So we have yet to define what hypertension is in our dialysis patients. The targets are also issues for discussion and debate, and we do not have clinical trial evidence using hard endpoints to define what is the optimal blood pressure in patients on maintenance dialysis. But we have expert opinion on the threshold that we should use to treat hypertension, and the targets that have come out of these expert opinions have been extrapolated mostly from studies in the non-dialysis patient population. One commonly referred to recommendation is to maintain the interdialytic self-recorded home blood pressure of to less than 140/80. You should note here that the recommendations are inclining to use home blood pressure rather than the pre and post dialysis blood pressure that I have emphasized are not very useful. When interdialytic self-recorded blood pressure is not available, the median midweek blood pressure of less than 140 in the dialysis unit can be an alternative target. But this is again an issue for discussion and debate. The emphasis that we should not use pre-dialysis blood pressure as a target should be recalled. So how do we manage hypertension in our patients in dialysis? Just like patients, non-dialytic patients with hypertension, we use a combination of non-pharmacologic measures and antihypertensive drugs in the management of hypertension. And in our patients on dialysis, non-pharmacologic measures related to volume control take the most important place in the management of hypertension. So achieving the dry weight, which I'll define in a minute, minimizing sodium gain in the interdialytic and in the intradialytic period, and avoiding short dialysis are among the non-pharmacologic measures we use to control hypertension. So dry weight is defined as the lowest tolerated post-dialysis weight, which is achieved through a gentle and gradual reduction in post-dialysis weight, at which patients experience minimal signs or symptoms of either hypo or hypervolemia. Defining dry weight is difficult. We generally assess dry weight clinically using looking at the presence or absence of edema, looking at the JVP, listening to the base of the lungs, and so on. But we know that the assessment of patient's volume status using clinical parameters has a lot of pitfalls. There are newer techniques that use biochemical measurements like proBNP and techniques like the inferior vena cava diameter, bioimpedance plethysmography, and lung ultrasound that one can use to assess dry weight. The newer techniques are definitely better, but they are not easily accessible. So we still fall to clinical parameters to assess dry weight. And we need to achieve dry weight gradually in a patient who is initiated on dialysis. We need to reduce dry weight gradually in the first few dialysis sessions by about 0.5 liters per session, and subsequently by about 0.2 until we achieve the dry weight as defined in the earlier slide. So we must take several sessions, weeks of dialysis in order to achieve dry weight. In the effort to achieve dry weight, we must also emphasize that patients should avoid weight gain between dialysis through salt and fluid restriction. Our dialysis nurses usually advise patients about restricting fluid, but fluid restriction without sodium restriction is meaningless. So it's sodium restriction that we must emphasize on, and the amount of sodium patients on dialysis should take is 1.5 grams of sodium or 4 grams of sodium chloride per day. And this allows to reduce the sense of thirst and reduces interdialytic weight gain and facilitates the achievement of dry weight and blood pressure control. Another contributor to weight gain is high sodium in the dialysate, which should be avoided as much as the circumstances allow. We should be able to decrease the dialysate sodium in the patient towards pre-dialysis sodium, or to a fixed number like 136 in patients who can tolerate that. When you use higher sodium, blood pressure tends to be stable. We avoid intradialytic hypotension and so on. But that creates a vicious cycle whereby there is increased weight gain. We then want to do more ultrafiltration and cause more symptoms in patients. So by aiming for lower dialysate sodium, we can achieve lower interdialytic weight gain, and that would contribute to achievement of better blood pressure control. We should also remember that some of the drugs we use, like sodium bicarb and potassium binding resins like sodium polystyrene, contribute to the sodium load, and we must avoid these if again the patient's circumstances allow. We all know that the longer the dialysis time, the lower the blood pressure, and this is largely through volume control and the reduction of dry weight. The story of the Tassin dialysis unit in France is known to all, whereby by using 8 hours of dialysis 3 times a week, they were able to achieve not only to have patients of all antihypertensive patients, but the survival of these patients is quite remarkable, much higher than any dialysis population anywhere in the world, and this is thought to be related to the longer dialysis time that helps towards lowering the blood pressure. But the problem with longer dialysis time, including using modalities like nocturnal hemodialysis and daily short hemodialysis, is the issue of practicability, particularly in our part of the world where dialysis slots are difficult to get, and we cannot afford to provide longer dialysis time as was shown in some of these studies. But we must make sure that at least our patients do not go below the 4 hours 3 times per week. That is quite standard. When we come to the pharmacological treatment of hypertension in dialysis, unfortunately, for many reasons, only a certain proportion of our patients will have their blood pressure controlled just with maintaining reasonable dry weight and low salt intake and so on. So most patients will require antihypertensives, and there is evidence that blood pressure lowering using antihypertensive agents improves cardiovascular outcomes, and this occurs regardless of how one achieves the reduction in blood pressure, irrespective of what antihypertensive agents we use. This is a meta-analysis of 8 studies that was published in the Lancet in 2009. The different studies used different antihypertensive agents, ARBs, ACE inhibitors, calcium channel blockers were used in some of these studies. There were a total of close to 1,700 patients, and in the final analysis, it could clearly be shown that patients who achieved the lower blood pressure had lower incidence of cardiovascular events, including myocardial infarction, stroke, and death. But which agents to use among the plethora of antihypertensive agents available to us will depend on a number of factors. Like all patients with hypertension, choice of agents will need to be individualized, although one can talk about agents of first choice, second choice, and so on. So what would dictate the choice of agents would be the presence of comorbidities, patient's blood pressure response to dialysis, the dialysability of the agents we use, and the side effect profile must all be taken into account when we use antihypertensive therapy in patients on maintenance dialysis. Generally, one would want to use long-acting agents that are non-dialysable and can be given once daily, after dialysis. Chronotherapy has become fashionable to talk about. Bedtime dosing, or at least some of the drugs, is theoretically expected to improve nocturnal dipping and might contribute towards better outcomes. But this is more theoretical than based on hard evidence. Although blood pressure therapy must be individualized on the basis of some of the things I mentioned, prominent people who have studied hypertension in dialysis, like Rajiv Agrawal from Indiana, the United States, prefer beta blockers as first-line therapy, and the reason given is that patients on dialysis are at increased risk of cardiovascular mortality related to the high risk of arrhythmias and sudden death. And in general terms, beta blockers are supposed to be better in this regard. And among the beta blockers, some of the drugs mentioned are atenolol. Atenolol is, by the way, dialysable, but it can be given after dialysis just 3 times a week at doses of 25 to 100 milligrams. Another beta blocker that has been studied and that has been shown in small studies to be associated with better cardiovascular outcome is Carvedilol, which is non-dialysable, and you'd prefer to use Carvedilol in patients who have intradialytic hypertension because it would remain in the patient's bloodstream throughout the dialysis period and may prevent rises in blood pressure during the dialysis period. Another group of drugs that one can very safely use in our dialysis patients are calcium channel blockers. Calcium channel blockers are generally non-dialysable, and among the calcium channel blockers, amlodipine, which is the most frequently used calcium channel blocker globally in the non-dialysis population, is an effective and well-tolerated antihypertensive agent that can be added to beta blockers. ACE inhibitors and ARBs are agents that one would use in a significant proportion of patients on dialysis because of the comorbidities and the presence of compelling indications for their use, like patients who have heart failure with systolic dysfunction, patients who've had an acute MI would need to be on either of these groups of agents. While most ARBs are non-dialysable, one must recognize that most ACE inhibitors are dialysable, and one must take into account in timing the dose of the ACE inhibitor. Fosinopril is the only ACE inhibitor that is not dialysable. Other groups of drugs, antihypertensive agents that may be used include mineralocorticoid receptor antagonists. At face value, one may be scared to use these agents because of the increased risk of hyperkalemia in these patients who are oligoanuric. But there are small studies to indicate that discontinuation of mineralocorticoid receptor antagonists occurs in less than 20% of patients who are given MRAs among dialysis patients. So they can be safely used in a large proportion of patients. And MRAs, as you know, are very useful in the management of resistant hypertension, as was discussed by the earlier presenter. Other agents that can be used when hypertension is still difficult to control after having used The agents I've described earlier include central agents like clonidine and vasodilators like minoxidil. So they can be used in a small proportion of patients whose targets cannot be reached after non-pharmacologic treatment and the agents discussed above. So before I wind off, I would like to mention a few things about intradialytic blood pressure changes, starting with intradialytic hypotension. Hypotension is a common complication among our patients on dialysis. And what contributes to hypotension are intradialytic weight gain. So when patients have large intradialytic weight gain, and when the dialysis time is shortened, would tend to ultrafiltrate patients very quickly, and that contributes to intradialytic hypotension. And this is a condition which is associated with increased risk of myocardial stunning and mortality, and may also contribute to vascular access thrombosis. And so intradialytic hypotension is a situation that we'd like to avoid as much as possible. And so that can be achieved by attempts to reduce intradialytic weight gain through sodium restriction, and one can also use dialyzable antihypertensives, so in these patients, and one must avoid taking an antihypertensive just before dialysis if one is to avoid hypotension episodes in those who are prone to intradialytic hypotension. So intradialytic hypotension leads to administration of additional fluids and would exacerbate the situation of weight gain and all the problems associated with it. In one of the earlier presentations, somebody asked about intradialytic hypertension. Intradialytic hypertension is also quite a common phenomenon. It occurs in as much as 15% of patients. And just like hypertension in general among dialysis patients, it's generally related to volume excess. So it's patients who do not achieve their dry weight, patients with large intradialytic weight gain who tend to have intradialytic hypertension. It's also possible that increased endothelin levels may contribute to intradialytic hypertension, and patients who take dialyzable antihypertensives might be more prone to increased blood pressure during dialysis when the levels of those drugs go down in the dialysis period. So the central theme in the management of intradialytic hypertension again is volume control. An additional measure one may take is using non-dialyzable antihypertensives like Carvedilol from among the beta blockers and the calcium channel blockers, which generally are not dialyzable. So I'll wind up by this slide summarizing what I've said in the last few minutes. Hypertension is quite common among our patients on dialysis. Volume overload is the primary cause for hypertension. Self-recorded blood pressure, home blood pressure, is a better tool to screen for and follow dialysis patients for hypertension. I did not mention ambulatory hypertension, blood pressure measurement, as it does not seem to be very practical. We have blood pressure targets that are mainly based on expert opinion. And the first means to reduce blood pressure is volume reduction in an attempt to achieve euvolemia. But most patients will require the addition of antihypertensives, and the treatment needs to be individualized. Thank you.
There's another question here from Dr. Kiapi. He says, could be I have missed as Dr. Wangare talked about secondary hyperaldosteronism as cause of resistant hypertension. Is Dr. Wangare there? Maybe she can answer. Razamund also has written a question. How common is He says, how common is hypertension in children?
Yeah, so in some of the studies I've reviewed, this is becoming a more recognized entity, and there are publications actually recognizing that dietary habits in children actually impact their cardiovascular health in adulthood. And most obese children actually end up carrying that obesity into adulthood. And I think my former classmate, Dr. Baga, did his thesis on hypertension in adolescents in Nairobi. And his findings were quite interesting. It's actually fairly prevalent between, I think his studies, if he's in the panel, he can take this, but I think it was reporting between 25 and 30%. In my research on salt-sensitive hypertension, I also came across various studies describing adolescent hypertension prevalence in adolescents in the US. Rates, depending on, again, this depends on where this studies is done, the diet, and whether they're obese or not, but the rates between 5 to 15% in some of the studies that I looked at. So it's actually being increasingly recognized, but the challenge has been the diagnosis of hypertension in children, because there are various charts for hypertension that at various age groups that you need to look at for you to make a diagnosis of hypertension in children. But it's an entity that needs to be looked out for.
Dr. Yewondesen, there's a question for you. Management of food balance at home for dialysis patients. And in addition to that, if you can also talk about intradialytic hypertension.
So fluid balance, as you all know, would depend on the residual kidney function of the patients. Patients who are who put out some urine, you can be quite a little bit more liberal in the recommendation for fluid intake, whereas patients who are oligoanuric would have to restrict their fluid intake to the bare minimum, just to take care of their insensible losses, 500, 700 mils a day. We should not forget that the foods we eat have water, and metabolism also generates water. So 500-700 ml plus the urine output is what one would recommend. But as I emphasized, restricting fluids without salt restriction does not bring about the desired result. So emphasis must be made on salt restriction. So intradialytic hypertension in children, how common? I'm very far from pediatrics. I take care of older people, so I did not really look into the issue of intradialytic hypertension in children, but generally intradialytic hypertension is present in something like 15% of the maintenance hemodialysis population. Thank you.